Hello, everyone, and hi from Denmark. My name is Ulla Møller Weinreich. I'm a medical doctor at the Aalborg University Hospital. I practice pulmonary medicine, and tonight I'm here with my very good colleague, Line, who is a respiratory nurse, and we will together talk to you about domiciliary high-flow oxygen treatment in COPD and chronic hypoxic failure. We will talk about feasibility, effectivity, acceptability, practicability, and cost effectiveness of the treatment.
Yeah, and this is our disclosure. Okay, so in 2018, we first published our results from the long-term effect of oxygen-enriched high-flow nasal cannula treatment in COPD patients with chronic hypoxemic respiratory failure. And today we are going to share with you some of our experiences from this study. What we saw in this, we had 200 COPD patients randomized in this study. Within the first month, 14% of the high-flow patients stopped using the device and 3% left the study entirely. And as you can see on the right side, the remaining 86% used the device for 248 days, 7 hours per day. We also saw that patients using the device at night or both day and night used the device significantly longer than those only using it during the daytime. By the end of study, 33% of the high-flow treated had left the study compared to 29% of the controls. And during the study, there were no adverse or serious adverse events recorded. After the study, we wanted to investigate the persistent use. So we looked at we looked back at these patients afterwards. And what we saw was that 1/3 of patients persistently used high flow 3 years after the end of the RCT study. And they still had, yeah, you can continue. Once more. And once more, actually. We also saw that the mean use of high flow did not differ significantly from the use in study. They still used it the same amount of time. And what we also saw was that 2/3 of those who died used high flow until time of death. So that was actually an interesting find as well. So by this, we mean that we are able to say that this treatment is feasible.
What did we actually look at in this study? Well, our primary endpoint was to investigate whether domiciliary high-flow treatment was able to reduce the number of exacerbations and hospitalizations. And in this slide, I'm showing you the results of on my left-hand side, the results of the exacerbations, where we could see that high flow significantly reduced the number of exacerbations. This both in crude numbers, but also when correcting for the time of use of high flow treatment, we could see that we had a significant reduction in number of exacerbations in these very severely ill patients. We also saw a reduction in the number of hospitalizations, not in the crude numbers, but when we examined again the months of use of high flow, we could see that in the high flow group compared to the controls, we had a significant reduction in number of hospitalizations. Another secondary finding was that the patients were relieved by judgment of the MMRC score of their dyspnea, and we also saw that they ameliorated their walking distance significantly. As a matter of fact, at baseline, the only finding that differed between the two groups was that the patients in the control arm had less dyspnea than the patients in the HFNC arm. So therefore, we were thrilled to find that already after 1 month, we saw a significant reduction in MRC score in the patients that were treated with high flow. Furthermore, we looked into health-related quality of life, and here we saw judged by the HDRQ, that patients had a significantly lower HDRQ compared to controls. In the treated arm, we saw that after 6 months, we had a clinically significant difference as well as a statistically significant difference between the two, and in after 12 months we saw a significant difference between the two groups. Another finding was that the patients in the high flow group were significantly different from patients in the control arm in terms of the carbon dioxide in the blood after 12 months of study. I will return to that in a little while. That is because we did 2 post hoc analyses. I said we did a bit more, but we'll take them bit by bit. In the first post hoc analysis that we made was an interest in what happened to the frequent exacerbators, and we examined those who had 2 or more exacerbations in study. Another post hoc analysis was the persistent hypercapnic failure in the patients. We had not there was not a exclusion criteria in this group of patients to have an isolated hypoxic failure. Patients were allowed to have hypercapnic respiratory failure as well. So those who had hypercapnic respiratory failure from inclusion, we had a second look at as well. And what did we find? Well, looking at the patients with frequent exacerbations, we could see that in those who had 2 or more exacerbations per year, we had in crude numbers a significant difference in the number of exacerbations compared to those who had 0 to 1 exacerbations pre-study, where we actually could see that patients increased the number of exacerbations. Along the same line, we could see that the patients with frequent exacerbations reduced not only a number of hospitalizations, but also days of hospitalization. In the control arm, we also saw a slight reduction in number of hospitalizations, but this was not significant. I need to stress to you that the small increase we saw in number of exacerbations in the group with 0 to 1 exacerbation did not exceed the difference we saw in patients in the control arm from the time of inclusion till end of study after 12 months. Furthermore, we did a post hoc analysis of the development in hypercapnic levels of over the 12-month period that patients were treated with high flow. And we can see from the table 1 included here on this slide that approximately 1/3 of the patients had hypercapnic failure at the time of inclusion. In the figure in the center of the slide, we can see that patients treated with high flow, which is the red line, decreased hypercapnic levels during the study, whereas those in the control arm increased the hypercapnic level during the study. Furthermore, we have here an illustration where we looked at the patients every time they came into the outpatient clinic. When we monitored them, we took an arterial puncture after 30 minutes of treatment with the high flow. And here we could see a reduction every time, which was absolutely similar for every time we tried. And the reduction we see here is an illustration of the clearing of the anatomical dead space for CO2. You may wonder why the reduction in the controls after 12 months for 1 is present, and secondly is much steeper. We offered all patients after the end of study to try out the high flow system if they wanted, and also to try it out at home. Therefore, we had a number of patients that we introduced to it at the end of study visits, and they also had a 30-minute arterial puncture done. The percentual difference in the hypercapnic levels in the control group here and the interventional group is exactly the same. By this, we mean to be able to tell you that this treatment is not only feasible, it is also effective in our very severely ill COPD patients.
Okay, so now we know that treatment is effective, but we also wanted to obtain further understanding on patient experience of this treatment at home. So we also did a qualitative study. So the aim of this was to explore COPD patients' experience using home high flow treatment. And the patients were included from the previous RCT study until themes were saturated. And by this, we included 12 patients, 5 males and 7 females, and 8 relatives participated as well. They were all using LTUT, meaning long-term oxygen treatment, and as an add-on high flow treatment. Data were collected using semi-structured interviews, and by thematic analysis, we did search for meaningful patterns and themes across these interviews. And we used a semi-structured interview guide with 4 themes to ensure consistency. And these themes were user-friendliness, treatment benefits and disadvantages, experience changes, and descriptions of daily use. And through the thematic analysis, 6 themes were identified as important to patient adherence. Firstly, reduced COPD symptoms. All of these interviewed patients could tell us about how they really ameliorated their symptoms, meaning they didn't cough anymore, they didn't have sputum anymore. So that really ameliorated their quality of life and their daily living. They also had perceived lower work of breathing. And all of this also improved their quality of sleep, actually, because when they didn't cough during the night, they had a much better sleep. And by this better sleep, it also increased their activity of daily living. And actually, they were also talking about the feeling of safety. Being able to get this treatment at home made them feel safer. And also the theme technology use was really important because all of these patients could tell us how easy it was to use the device. So that didn't give them any problems at all. So to conclude something here, we could see that patients experienced symptom reduction when treated with high flow nasal cannula, including a perceived lower work of breathing. And the symptom reduction improved their quality of sleep and increased the activity of daily living, both physical and the way they could eat and socialize with friends and family. So furthermore, important for patient adherence is perceived usefulness and ease of use of the device. So by this, we mean to be able to say that this treatment is also acceptable. But we also want to share with you some of the ways that we have implemented this treatment in Denmark. So now we are going to tell you a little bit about how we do it practically. We have made a national Danish guideline for home high flow treatment. And the indication of this treatment is chronic hypoxic failure patients with either interstitial lung diseases or COPD. Chronic hypoxic and hypercapnic failure can also be a target group if home NIV are not tolerated by the patient. And it can also be considered for patients with bronchiectasis with daily sputum production and frequent exacerbations. And high flow treatment is to be used as an add-on to LTUT treatment. Most of the patients that we do send home with high flow are already in LTUT treatment, even though Ulla and I have tried to send home a few patients that were not on LTUT treatment, but who had severe sputum problems. And we also saw a really good amelioration there. Patients are encouraged to use the treatment for a minimum of 6 hours per day, preferably at night, because we saw earlier in some of our retrospective studies that the ones using it at night used it a bit more than the ones only using it during the daytime. but they can use it as much as they would like to. The flow must be a minimum or a bit more than 20 liters per minute. And we want to do a higher flow if they have hypercapnic failure and if patient can tolerate a higher flow, of course. Treatment are initiated in an outpatient clinic or under hospital admission. And we do recommend to have a telephone consultation after 1 week by a nurse. That comes from the RCT study, the experiences we had when most of the patients that dropped out or discontinued treatment did it within the first week or within the first month. So we know that the first week to get adapted to this treatment at home is the most severe one. So we do have to call them after 1 week to ask if they have any problems or questions to the treatment and to encourage them to keep on going. And after this, we will have an ambulatory visit every 6 months, as we do already with the LTUT treatment. So we control both the LTUT treatment and the high flow treatment at the same time. To do startup, the first important thing is to choose the right size of OptiFlow. I often get the questions from other wards in our hospital. Is it okay for us just to buy medium size of OptiFlow because they can fit everyone, can't they? The answer is no. It's really important to choose the right OptiFlow. It's really important you look at patient's nose. It's not the size of the nose, but the nostrils that tells you how big, which size you have to choose. You can choose an OptiFlow in 3 different sizes, small, medium, and large, and actually there are quite a difference there. And the best way to say it is as large as possible, because it reduces noise and improves adherence for the patients. So if you can fit in a size large, do that. When we start up, we start at a flow on 15 liters and we increase until target flow, meaning if this patient are in need of a higher flow because they are a bit hypercapnic or if they need more support, we will try to put them maybe on 40 or 45 liters. The most part of patients we send home are between 25 and 30 liters per minute. It's really important to be aware of patients' accept, because if the patient can't accept the treatment on 30 liters, why do you want to send them home with 30 liters? They're not going to use it. So it's really important that you talk to the patient during this tryout. And when you are on the right flow, after this you titrate oxygen to obtain an acceptable saturation. You have always a target saturation, maybe on 90% or something like that. And you will just try to titrate oxygen until you get to the saturation. And you should always aim for temperature on 37 degrees, because that's where you get the most humidity. But if patients are feeling discomfort, you might try and reduce the temperature to 34. And you can increase again after adaptation. Maybe you can do that already while you try it out in the ambulatory, or you might be able to do it after a few days or after a week or 2. But when they get adapted to it, most of them will be able to get 37 degrees, our experience. It's also important to give them some information about the treatment and especially possible adaptation problems. If they have really dry out airways, they can experience to begin with their nose is running because they can't take all this humidity to begin with, because they're simply too dry. So it's really important to tell them some of the stories about the other patients that you have seen before, that this is normal and it will get better during a week or 2, maybe 3 weeks. So it's important to talk to them about these issues. After we have seen them on the same flow rate for 15 to 20 minutes, we will take a control arterial puncture. And after this, of course, it's important to have the doctor's prescription. And in Denmark, we order the treatment at the oxygen suppliers. Those are the ones that will deliver the device and all the supplies for the device. And we also, of course, have to document this in the medical records. So we will also say that this treatment is really practicable.
Now, Line and I, we are from the part of Denmark called Jutland, and this part of Denmark is inhabited by farmers and very down-to-earth people. So we are quite we quite like when it's what we do is affordable and we actually can see value for money in it. So therefore, we also set out to find out whether high flow treatment is cost effective. We did that together with our very good friend and collaborator, Sabrina, who's a health economist. And this year we published a post hoc analysis on the cost effectiveness of domiciliary high flow nasal cannula in COPD patients with chronic respiratory failure. And I'll try to talk you through this because this for healthcare personnel, me included, I have had to learn it too, is perhaps a bit difficult to comprehend. Now, for one, what we did was to assess the cost utility, and we did that by looking at the outcome measures that were used throughout the healthcare sector. And we used the costs for the year that we included the patients, and that was calculated to what is called quality adjusted life years quality, which is a central part of health economy. Quality is a combined measure that takes both the quality and the quantity of life into account. The analysis after that was conducted as a within-trial analysis and was performed in concordance with all the international guidelines for this type of analysis. The time horizon for the cost utility analysis followed the clinical trial, as I said, and it went on for the 12 months that patients were included. And there was no discontinuation, there's no discounting done in this study. All costs were calculated in 2019 values, and we used the Danish Consumer Price Index to set a price to all the included parameters. The costs were first calculated in Danish kroners and then converted to British pounds sterling after an exchange rate from the time. All the 200 patients that participated in the trial were included. The 33% that did not complete the study were also included, and the missing data from these patients were handled by using multiple interpretation. Cost of days in hospital and outpatient visits and emergency room visits and scheduled and unscheduled GP visits, medication and equipment for the high flow were included on all the patients. And then we were lucky enough to have a subgroup of 100 patients, and this is not even, it's not even something that we aimed at, but by chance, they were 50-50 within the group of the patients in the intervention group and the controls. And they lived in the municipality of Aalborg, which is the largest municipality in our region, where the entire study population is gathered from. On this group of patients, we did, by courtesy of the municipality of Aalborg, get the cost of home nurse care, in-home assistance, household cleaning, telehealth care, and rehabilitation, so we could include them in the analysis. A mean European price for myAirvo was used in this study, as well as for the consumables. And the cost for setup and service was based on the Danish prices. We used the SGRQ scores to convert into the cost utility values, the EQ5D3L values, which are commonly used for health economy analysis. Those who died during the study received a value of 0 in this score. Based on the cost utilities, the EQ5D3L quality adjusted life years were calculated using a linear interpolation, and from this we calculated what is called the incremental cost effectiveness ratio, And to explain to you what this is it's the mean difference between the costs divided by the mean difference in QALYs between the two groups in this study. And here you see a baseline table from the study. A lot of these data are data you can also see in our original RCT, but we have also included here costs of admission in the year preceding to inclusion, number of emergency room visits, and the costs in the year preceding in terms of municipality costs, and also without these costs. We did a mean unadjusted resource utilization and cost per patient in the group and the controls presented into these different cost groups. And as you can see in the baseline here, there were no difference between the two groups. When looking at the 12 months, 6 and 12 months data on these patients, there were, of course, a higher cost to the HFNC group based on the utility alone. Furthermore, we did a mean unadjusted cost per person in each group for all categories within the 12 months of follow-up. And we could see that compared to the control group, the HFNC presented with a somewhat higher mean cost for hospital admission, but at the same time, a lower municipality cost. For the final analysis, we did 5 different scenarios. For one, we did a complete case-based analysis. And when doing this, we could see that the probability of this treatment being cost-effective was 83 to 92%. Furthermore, we did an analysis where we did not adjust for treatment days. And I ask you to bear in mind that we had quite a lot of patients dropping out within the first month. But even when adjusting for that, we could see that there was a probability of 75 to 83% of this treatment being cost effective. To try to accommodate our results so that people from other countries, for example, Colombia, could relate to them, we did a scenario where we did an analysis varying the interventional costs plus minus 30% of the European costs, so that you could sort of relate to the interventional costs in your own country. And as you can see, if we increase the costs, we had a probability of the treatment being cost effective of 72 to 85%, whereas if we reduce the cost with 30%, we had probability of the treatment being cost effective of 90 to 96%. Finally, we did an analysis on the 63 patients where we had a complete data set. And looking at those patients, we could see that there were a probability of the treatment being cost effective of 91 to 97%. And that is actually quite satisfactory for people from Jutland, because we mean to be able to sum up for the economist part and say that domiciliary high flow treatment is very likely to be highly cost effective for patients with severe COPD and persistent respiratory failure compared to usual practice. So if we are to sum up this little talk for you, we would like to say that treatment with high flow nasal cannula is feasible, effective, acceptable, practicable, and cost effective. And by that, we would like to thank you for your attention.
Thank you very much for your presentation. It really covered many of the aspects of high flow nasal cannula treatment at home. Also, it was a pleasure to listen to the facts direct from the author's voice. I think that your study had really good outcomes, such as exacerbation rates or quality of life improvement, despite the fact that mortality did not significantly change between groups. I was asking myself, as I was listening to you, how did you establish the initial flow rate and the FiO2 in this chronic COPD patient at home? As I know, you recommend to set flows at least of 20 liters per minute. In my experience, as I work in the acute field, from the beginning, I would have thought to set flows a little much higher, from then reduce them to achieve comfort if it's necessary. So what is it for you more important, to set flows from the patient comfort target or from a clinical outcome side? Since, as you showed in your post-hoc analysis, that even with these flows, PaCO2 did decrease, and this is the first study to demonstrate this long-term PCO2 reduction effect.
Should I start and then you can start? Yeah. Well, I mean, it's very important for us to get the patients to use the high flow treatment. And therefore, the comfort is, of course, mandatory. Otherwise, they just don't treat it.
Yeah.
They'll call Lena and say, I won't use this. So, of course, it's sort of a mandatory thing to get them to accept this. We are getting more and more aware of the problem with side flow. We need to get the flow a bit higher in order to avoid this. When we did the actual study, we started off doing a small pilot study sort of to establish which flow to use, because we didn't know.
No, and we did that on 25 actually. But the patient felt most comfort on 20 liters. So we decided to go with 20 liters at that point of time. And today we still have a few patients actually at home with 15 liters. Sometimes we have to choose what the patient can cope with. Because if we want to send home a patient with 60 liters and they're not going to use the device, it's not going to help anything. But still, we also have patients being sent home with 60 liters by some of our colleagues. We would never do that. But they can't hear the TV, they can't do anything, but they're using the equipment because the doctor told them to. But they have so much discomfort. But I think we can, as long as we get more experienced sending patients home with this. We've done it for years now. So today I would maybe go a bit further. If I have a patient that say, okay, I can cope with 20, maybe if I wait 10 minutes, and if I explain to the patients why I would like to increase it to maybe 25 or 30 liters, that will often help the patient understand why do I want to do that? And it's exactly the same with the temperature. If I explain to the patient, why is 37 degrees better for you than 34, it gives them a point of view that makes them easier to decide to go with whatever I say. So it's important that we do that in a language that they can understand. So if we are going to use the time to explain good to the patient, why do we want to do it like this? I think most of the time we can get them to go with what we're saying.
And then, of course, it's very important to stress that, as you said, Laura, you're working in the acute setting. We also use a lot of high flow in the acute setting in our hospital, and we use totally different flows there. So there is a very big distinction between how to treat a patient in hospital, and then if we find during the hospitalization that it would be beneficial to this patient to use the equipment at home after discharge, then at the end of the admission, we start turning down the flow and try to sort of gently establish the treatment that we expect this patient to continue with after discharge.
I totally agree with you. When doing non-invasive respiratory supports, such as high-flow nasal cannula, NIV, CPAP, I think that negotiation with the patient and explaining the patient what we expect and what he or she should give us so as to have a good outcome is the clue. Even in the acute setting. Yes.
It's a bit of,
but it's even more difficult when it's at home. They have to use it every day, and we are not there beside them. So
we are not there.
No. So, sometimes I have thought that I may have to make a full-size carbon figure of Line that I can get the guys from the oxygen company to set up by the end of the bed. So they have her with them every night saying, use your equipment. It needs to be at that flow. It needs to be at that temperature. I think that'd be good.
Talking about the night, you rightly mentioned that daytime high flow nasal cannula users use less the device than nighttime users. In your opinion, what justifies this? Is it a patient-related cause or is it a device-related cause? And how do you imagine, this is maybe an ideal question, how do you imagine your ideal high-flow nasal cannula device for home?
The reason why they're using it less during daytime is a mobility question. It's because it's more difficult to walk around with. But we have stands, and the patient that want to use it during the daytime, it's really important they get a stand and that you explain to them, or the guys from the oxygen supply company have a really important job to do to explain to the patient and show them how can they do with a cohort so they can extend their walking distance and walk around in their home with the stand. But if they have to figure all this out themselves, these are severe ill patients. And if it gets too complicated, they won't use it. So it's really important to train the guys from the oxygen company to help the patient sort out these problems at home as well. How can they walk around with it? Because we have had patients using it in their summer house or on their terrace during the summertime. So they can go around with it, but it's a bit more complicated to set up maybe for some.
We had a patient in our study that was he participated when we first published. We had the fortunate possibility of getting on national television, and they also wanted to visit a patient. And this patient had a greenhouse which he loved passionately, but he hadn't really been able to go there for a long time because he was in a very terminal stage of his COPD, and his children and his wife managed to get a system established so he could have the electricity in his greenhouse, and he used the high flow system in the greenhouse, and he was very happy. And I think one of the things Nina is talking very much about the oxygen company here helping the patients out. In a lot of countries, we don't have this kind of collaboration, we know, and I think a resource person or resource you need to look into will be the relatives. It will very often be the relatives that you have to sort of feed these ideas into for them to elaborate on when they come home with the patients. In our experience, we now have a lot of patients in the very terminal stage of their COPD. We also have patients who actually use NIV at night, and then they use the high flow during the daytime. And they're something that gives them quality of life. And for those patients, it is important that whatever little range of mobility they have, which is very often only their homes, that they can move around there.
And that's also why it's important that they can call up someone in the hospital, or we call them after a week and maybe again after a month. I just recently started up a new patient on high flow, and he had some problem to begin with, and he only used it during the daytime. So I talked to him every second week just to try to talk into these small problems. And when we had solved all the problems, suddenly the last time I called him, he said, okay, now I can sleep with it all night. So it only took me a few calls, maybe 10 minutes each time, to talk to him about his small problems. And after that, when we have solved them, everything went well. So it's not that huge amount of time you have to put into it, but sometimes we have to do an extra follow-up just to help them with these small problems, because a small problem can turn really, really big if you don't have any resources yourself.
Now, talking about practical aspect and follow-up, How do you know, or how can you measure that the therapy is carrying your patient to better outcomes? Or in how much time do you expect an improvement? Or what would be the clinical goals expected with a high flow nasal cannula at home, or when to expect them?
Well, we still would like to use the high flow system to reduce the number of exacerbations and to see if we can avoid some of the hospitalizations. So that is still an outcome. We also would like to see our patients to have a better oxygenation. And apart from that, it is very much the comfort and the quality of life that we have a focus on. We are not in doubt that if we did a long-term study, a very long-term study, we would see that this treatment improves the duration of life considerably, and probably also significantly. We still have, I don't know how many people we have now.
I still think we have about 20 patients from the original study alive using high flow.
And you need to bear in mind that these patients, when they were included, they had on average used oxygen treatment at home for 18 months. So there were very severely ill patients even when we included them. And therefore, we are pretty certain that that this adds a year to life. So we are we would like to improve the oxygenation, we would like to reduce the exacerbations, and we'd like to reduce the hospitalizations, but very importantly, to ameliorate the quality of life.
And by that, the COPD symptoms, because that's the main thing. I think already after a few weeks, maybe a month, patients are talking about how they have less sputum. And the sputum, I've always known that sputum is a huge problem for these patients. But what I saw in the qualitative study was that patients actually, they stayed at home instead of going out to dine with friends and family, because they always was aware if they're going to cough up sputum during a meal. So they didn't want to go out and socialize with other people. But after they had their high flow system, they didn't cough up sputum anymore. So they could go out and about more. And that really brings quality to life for these patients. So they have much more energy when they don't have to start their day by coughing up thick sputum. So that's really one of the things, I think, really ameliorated things for the patients, that they're off with the sputum.
So the follow-up in the initial periods or the monitoring, it's more often that maybe when the patient get used to?
We most of our patients, we only have very few that do not use supplementary oxygen during the high flow treatment, and we actually just enroll the high flow controls in the oxygen controls. And we usually, in Denmark, we usually see patients on long-term oxygen therapy in the outpatient clinic every 6 months. So we do the same. We look at the high flow at the same time when they come to us. We do a high flow control where we talk to them about the adherence to the system, and we find out whether we need to adjust both the flow but also the level of oxygen given during the high flow treatment. Discuss whether there are any problems with the treatment, and
often we do change the OptiFlow size, because lots of patients still get sent home with a medium size. So often I will go and change them to a large.
Danes apparently have very large nostrils. It seems, So that's what we do during the follow-up. And we of course look at there are patients, especially those who do not tolerate NIV treatment at home. If they increase in hypercapnic levels, we may try to increase the flow a bit to see whether we can do a slight reduction in CO2 by that as well.
Okay, now I have a question changing just a bit the clinical aspect of this. in your cost-effective study, that it also was really hard for me to understand it. You saw that, as you said before, that home high-flow nasal cannula is likely to be highly cost-effective. However, does health insurance company perceive any saving in the treatment of this patient at home? How it can be measured, these savings?
The savings, you should look at the same things actually as we look for as clinical goals. It's important to understand that in Denmark, all healthcare is paid by the government. We pay high taxes, and in return we get free healthcare, including high flow treatment. But when we have to persuade, we know from colleagues around, especially around Europe right now, that they are talking to insurance companies of whether to reimburse high flow treatment or not. And the thing that you should argue is that if we can reduce number of exacerbations and we can reduce number of hospitalizations by this treatment, this is highly cost effective. You know, in Europe alone, 6% of the European health costs goes to COPD patients, and the majority of those is to pay for COPD exacerbations. If by that also we can keep the patients more mobile, and in Denmark we also get free or almost free care at home. You can buy supplementary care at home yourself if you want to, but we by our taxes we also pay for home care and home nursing. And we could see significant reductions in the care that patients needed at home. So these would be arguments to present to an insurance company and see, you can actually, is this beneficial for you to offer this treatment to patients if we find indication, because you would be able to save money on exacerbations and home care for these patients.
You're right. Maybe health, or we treating patients, we don't realize or we don't think in these aspects, but it's really important to think like that, or to think outside or moreover the clinical aspect, because it's money that all together we pay.
Yeah. It's our common, especially when we pay them during taxes. It's our common money here, and I think it's actually very important to address the economy for everything, but also for high flow, because all around the world people get older, and we see COPD probably being the third most frequent cause of death in the world within very few years. And this is a massive disease worldwide. And if we can do just a little bit to reduce costs in these patients, it would be beneficial for us all. It would give us money to think about green energy and electrical cars and whatever have you, that is also good for this planet, to be able to reduce health costs. And this is a significant group to look at. Yes.
This time I have a very difficult question for you, because whenever somebody asks me this, I really don't know what to answer. In your opinion, which patients should not definitely use high flow nasal cannula at home?
Could you just repeat that, because there was a slight thing with the sound, yes. Laura?
In your opinion, which patient should not definitely use high flow nasal cannula at home?
Well, do we have any that shouldn't? If we look at the post hoc analysis, then you should think perhaps twice if you had patients completely without exacerbations. Then there's perhaps not much to gain.
Okay.
So these would probably be the only ones that I would be a bit aware of. Then we have a few of our terminal patients with lung cancer who has a permanent thoracic drainage. That doesn't work well at home with the repression, the humidity. That seems not to work well. But apart from that,
I think that actually in our oncology ward, they have just started out using high flow in the ward. So I think it's just a matter of time before they're going to try to send home patients on hospice or at home, cancer patient with high flow, because it gives them more comfort.
Our hospice is very, very fond of the treatment with high flow because it relieves the patient. It reduces the work of that. Has not been a topic of our talk tonight, but it definitely reduces the work of breathing. And for the very severely ill patients of various reasons, this is a comfort to them. So actually, the only patients I could think of. Well, it all depends what you want to gain from it. But if you look at the group that we've been looking into, patients without exacerbations are probably not the target.
And none of
I think that your answer is really wise, because thinking about the cost effectiveness, we want to save money and also not recover the patient. So your answer is really wise. I will use it if you will let me.
Feel free. You can borrow anything you want.
Thanks. So as to conclude, last question is, in your experience with chronic patient using high flow nasal cannula, apart from this patient, do you have experience with other type of patients, such as post-COVID, pulmonary fibrosis, or palliative care at home?
Yeah. Well, the very first patient that Line started off with was a patient with pulmonary fibrosis. And we also...
So that was even before high flow, actually. That was just a humidifier and 15 liters of oxygen, actually.
But we actually just completed a small study on interstitial lung disease, just a pilot study. And it's feasible too. This has only been a short study, so we don't see the amount of results we have in the COPD group. But it's absolutely possible. And I know that our Danish National Transplantation Center uses quite a lot of high flow for patients with interstitial lung disease as well. And that is for the purpose of reducing their breathing, work of breathing. I have quite a few, or not quite a few, but I have some patients with the bronchiectasis, and also patients with the tracheo and bronchomalacia that I treat with high flow as well. And
you can say every patient with sputum problems, actually.
Yeah. But in the bronchiectasis patients, I have seen a very large reduction in number of exacerbations. I have a patient now. I only have one at the moment, but I have a patient who is a carrier of cystic fibrosis and has some of the symptoms. And I know that the cystic fibrosis center in Copenhagen is looking into high flow treatment as well. So it is usable in very many different patient groups, but sputum is a bit of a key word.
Well, thank you very much. It was for me a pleasure to hear the authors and to hear your experience in this field, not only in the clinical field, but in the research field that it's so difficult to do. So if you want to add something.
No, I think we can just say that we've had fun doing this, and we're still thrilled. I mean, especially Line. She can get sort of a I don't know. She looks a bit like an angel every time she's put a new patient on high flow.
I did that Monday this week, and it just saved my day. And it wasn't even my patient. It was a patient. One of my colleagues, she had a patient in her room, and she was just asking me a question, and she was coming to me with an arterial puncture, and I was like, oh, shouldn't we try out high flow on her? I'll just call and ask a doctor if she's with me on that. And of course, the doctor was convinced because I can be really persuasive.
Yes.
When I get it was a good idea.
Yeah.
And just to see that when you put this on the patient, she was like having trouble breathing. She was using all her muscles, she was like really struggling to breathe. And she was there with her daughter, and she was like a terminal ill COPD patient on oxygen. And after just 10 minutes on high flow, she was just completely relaxed, and she was like breathing normally. And her daughter was looking at her, Mom, you look like you're feeling well. I haven't seen you calm in a while. So that's it for me. When I have a patient like that, I can smile the rest of the day.
And the rest of
it happened to me in the acute field, so I am totally agree with you. Well, thank you very much.
And thank you to you. It's been interesting talking to you.
Yeah. Nice to see you.
Hope to meet you again sometime soon.
Personally.
Yeah.
Ciao.
Bye-bye.